Today we're going to talk about fertility outcomes in post-uterine sparing surgeries for postpartum hemorrhage or PPH. Our discussion focuses on a literature review and discussion, and the group members are Eric, Daniel, Alfred, myself. We are supervised by Dr. T.C. Tan as well as Dr. Sonali. Today for our presentation, we are going to give a brief introduction of the topic, as well as provide a patient case scenario, followed by the actual critique of the article based on the systematic review. We are also going to talk about the KK experience as well as study conducted in KKH on postpartum hemorrhage, followed by a conclusion. Now, introduction. Why is the topic of fertility outcomes in post-uterine intervention important? Because health is not just a concept, but a state of complete physical, mental, and social well-being, and not just simply about the absence of disease. The case we are presenting is a case of Mrs. P, who is a 29-year-old G2P1 female at 29 weeks gestation. She basically presented with PV bleeding associated with abdominal pain. The bleeding was noted to be fresh, without clots. She had no prior pervaginal bleeding during her pregnancy. Routine antenatal bloods were normal. Currently, she has no fever, headache, or hematemesis. She also has no history of falls or trauma. Obstetric history-wise includes intrauterine fetal demise at 24 weeks gestation previously, delivered by lower segment caesarean section for preeclampsia 3 years ago, complicated by PPH. Code green was activated 3 hours after admission based on non-assuring fetal status. The baby was 1.3 kilograms, delivered by LSCS, complicated by a tear in the bladder serosa with significant PPH and a blood loss of 2.5 liters. Following which, a uterine compression and B-Lynch suture was done. Post-op wise, her recovery was uncomplicated. The patient was discharged well post-op day 5. Now, based on the case, what are the considerations that the patient might have? Of course, the patient might definitely think about whether she can get pregnant again, the risk to her pregnancies, especially subsequent pregnancies after this episode of postpartum hemorrhage, which is a complication of pregnancy, and if possible, when is the best time to get pregnant again? So the article we're talking about is actually this article on menstrual and fertility outcomes following surgical management of postpartum hemorrhage, a systematic review. For the article, they use a study selection and literature search involving the following databases. Data extraction-wise, they've studied the characteristics of trial participants, the types of intervention, the time of follow-up, outcomes, complications, as well as a quality assessment of the procedures done. Now, basically, this slide is the most important slide of the whole article. Mainly, they focus on 3 procedures, which is pelvic and uterine artery embolization, uterine devascularization, and uterine compression sutures. If you note, normal resumption of menstruation was 460 out of 503 patients, which was 91%, out of which 168 women desired future pregnancies, and the number of patients who actually got pregnant was 126, which is 75%. Patients with recurrent postpartum hemorrhage is 18. For the next procedure, uterine devascularization, 28 out of 32, which is close to 88%, had normal resumption of menstruation within 6 months, out of which 39 desired pregnancies, but only 33 actually achieved pregnancies. For the uterine compression sutures, 65 out of 71, which is 90.27%, had normal resumption of menstruation within 6 months, out of which 28 desired pregnancies and 24 actually achieved pregnancies. If you look at this slide, it seems that the number of patients who have post-procedure complications is the lowest in the uterine compression sutures, where there are actually no complications in terms of preterm labor, early pregnancy loss, as well as recurrent postpartum hemorrhage. However, the data does suggest that the pelvic uterine embolization is the most studied procedure in this paper, but we actually noted that patients who actually undergo this procedure are actually stable or patients who actually need to be stable, because such procedures are interventional radiological techniques and require the expertise of interventional radiologists on standby. As for the reported complications and association, we are going to look at embolization and devascularization techniques, as well as uterine compression suture or the Bielan suture. For uterine artery embolization or pelvic devascularization, complications included endometritis and as well as endometrial ischemia, uterine synechia and amenorrhea, or what's otherwise known as Asherman syndrome, increased risk of abnormal placentation in subsequent pregnancies. For uterine compression sutures, which is the Bielan suture, complications such as uterine synechia and amenorrhea or Asherman syndrome have been reported. The article basically reported that most women do not have adverse menstrual and fertility outcomes following surgical intervention of severe postpartum hemorrhage, as shown in the slides. The strengths of this paper generally was that a wide range of studies were reviewed because it was a literature review. The studies were prospective as well as retrospective. They were drawn from all around the world and did not focus only on British journals, but also through a majority of articles from Europe as well. The use of common endpoints to compare each study was also a strength of this paper. The authors provided good discussion on limitations of studies done, as well as some conclusions. However, the weaknesses for this paper are that the quality assessment of selection was subjective because the endpoints were not really very clear. No randomized control trials were done in the papers reviewed, but only prospective as well as retrospective studies based on the complications. There was insufficient representation of compression procedures in the meta-analysis, such as the compression sutures. We are now going to talk about the experience and study in KKH. Complications and pregnancy outcomes following uterine compression suture for postpartum hemorrhage, a single center experience. Basically, the KK paper studied 59,655 deliveries over a 4-year period starting from 1st January 2008 to 31st December 2012, out of which 23 deliveries required Bielan sutures to be performed as a result of postpartum hemorrhage, and out of which only 3 pregnancies were achieved following Bielan compression sutures. As mentioned, there were only 3 pregnancies in 2 patients reported from this study. For patient 1, she had a miscarriage in the first trimester. The second successful pregnancy was a 39-week pregnancy, which was delivered by elective cesarean section due to a placenta previa as well as a transverse lie. For patient 2, it was also an elective cesarean section for a term baby at 39 weeks. If you look at the picture in this slide, it showed that for patient 2, following Bielan compression sutures, this picture was basically taken at the cesarean delivery of the second baby following the Bielan compression suture of the first pregnancy as a result of postpartum hemorrhage. This picture basically shows fundal distortion, which is a complication noted for Bielan compression sutures. So basically, uterine compression sutures have been shown to be effective at preserving the uterus as compared to procedures such as hysterectomy. The risk of loss of fertility and subsequent pregnancy outcomes remains, and the total risk remains unknown. So while adverse pregnancy outcomes have been reported, there have still been successful conceptions and deliveries following compression sutures, such as the 2 successful pregnancies reported in this paper. The low rates of successful term pregnancies following compression sutures may be related to factors which are non-medical, such as psychological stress from traumatic delivery, causing mothers to choose not to have subsequent pregnancies. Most women do not have adverse menstrual or fertility outcomes in the long term after uterine sparing surgical procedures due to postpartum hemorrhages, basically from all the papers we have seen. Data from the 2014 paper from KK, which studied fertility outcomes after Bielan suture, are consistent with the other studies. Adverse outcomes in subsequent pregnancies remain restricted to isolated case reports, and the study and follow-up for this cohort of women remains very important. So now going back to the conclusion slide, the questions frequently asked by women, can they get pregnant again? The answer is definitely yes, because such procedures aim to preserve the uterus, and that most women actually resume menstruation as chosen to be a endpoint or parameter to measure fertility. In terms of risk to the pregnancy, it seems to be comparable with patients with past abdominal pelvic surgery, basically because all procedures done have complications and that they are no different or no higher than patients undergoing normal pelvic surgery. As to the question of when is the best possible time to get pregnant again, there are basically no guidelines as of yet, but the anecdotal advice is to wait 1 year or more to allow for healing of the uterus to prevent possible complications. Thank you.